health. You can do all sorts of cool stuff.
Can I interrupt for a moment?
No.
Oh.
Okay, thank you.
Now we've got a.
Thank you for letting me interrupt, Dr. Gawayne. I wanted to let everybody know that we are live on YouTube now, and we're being joined by however many people join us. We'll throw out the number every once in a while to let you know. We do this in the office of procedure sometimes too. So Ethan will be able to tell us how many, and he'll be controlling which camera is looking. And with Thomas, we'll get it up on the screen. You should be able to use that link now to see the comments. Hopefully they're all. I'm so sorry for interrupting. I need to ask Ethan, you have an audio on the one that says line in is the one that's on this mic. And then the one on Ken's is the one that says generally you want to have just one. Whichever one, like some of the others that are one younger, we'll have Kim up a little closer. We'd like to have everybody be a part of this. You? I want you to stay close, but Kim really close. We want you up in the front. Okay, yeah. Is that actually on YouTube? Okay. So you'll be able to see the comments. We can't see the comments.
Hopefully they're high school.
I'll show you how to. Yeah, it will be delayed. Can you minimize that?
Yep.
And the reason I want to do that is so that you can see the comment or the chat. Here we go. That's the chat.
Okay, right here.
That so you'll see it. So you can pass
like
along
this.
ones that are really really good. Pass along.
Okay. So but you want me to leave like this?
Oh, I guess you have to first to be able to see the comments. Okay. Okay. Thank you for the. It does what?
Everybody say hi.
Everybody's saying hi. Everybody's.
Anna Gurley.
So how many do we have? We've got 13. We'll get a lot more as we go. So you're
type in your comment. There you go.
Yeah, you can.
You
Totally
don't
can.
even need to raise your hand.
People in Texas are watching us here. So
Probably get an international audience too.
yeah.
Yep.
Yeah. Okay. So Thomas. Mr. Schroeder is asking how I got started doing this. I've always been interested in broadcasting. Okay, we're supposed to subscribe to Copy Baxter.
Nice.
Yes.
Okay. Everybody subscribe to Copy Baxter.
Shameless. I like
Good. That's how I got to where I am. Always an interest in broadcasting. Before I was pre-med, I was a broadcasting major, would make productions on television and be in the news and be in the radio station before becoming pre-med, and that's always stuck with me. So with YouTube being a necessary part of any business that's at all with what they're supposed to be doing, you get a YouTube channel and you start making videos, and of course with my interest in video and filmmaking, I just kind of let it grow to what it is now. The Auburn Medical Group channel here with 104,000, I guess it says now. By the way, click on the bell icon so you get notifications when we're live.
It's going to be 104,000.
And I have to apologize to people who are watching the video after the fact, because not everybody watches it live. Some people come to the channel afterwards and watch it. And my apology to them is sorry that we're interacting with people in a live audience and you're watching it afterwards. That's not quite as much fun, and it's not edited, so I'm sorry about that. We're going to have some fun here today with liquid nitrogen. I'm going to have a treatment done that I've never had done to me before. I'm of that age. I'm kind of like your principal. I'm needing to. Of that age. Okay. For those of you who don't know, Dr. Gawayne is 12 years younger than myself. I graduated in '88. He graduated in 2000. And I did not get to have Mr. Schroeder as a biology teacher. He was at Colfax then. Yeah, I had Mr. Hickman, who he worked with, and
Hickman was here when I was here.
he was here when you were here?
Yep.
He went on to Colfax. And he takes credit for being part of the inspiration for me going to school. If you know him, you know that he would do that. And we'll allow him. Harry, if you're out there, thanks. We have done this before with, have you shown them the cyst?
Oh, yeah.
There is a video on our channel about high school surgery, and it shows you can see the scar here on my neck, and I'll let the camera get closer on the scar. Right there, that's where he took it out. And Mr. Schroeder brought the cyst. That's what was that 2 years ago?
Was it 2 years?
It was October.
Yeah.
October 2 years ago, Dr. Gawayne removed that. Yeah, we cut it in half, right?
We
So
did cut it in half.
you
I
can
think
see
it
it.
sort of globbed together again.
And I think we passed it around the classroom
did.
for
It
students to
was
smell.
Nasty. It was nasty. You
Oh,
can
yeah,
always.
we cut it open, huh?
We did. Remember?
right,
We
that's
walked
right.
around it.
Yeah, yeah.
Do you want it back? Do you want to put it back in again?
This?
We've
yeah.
never done that.
We could do a cyst transplant.
Too far, we will block them. Do we have?
The chat is incredible. Okay, so sometimes things like that happen on live view. Oh yeah, we got to copy Baxter. What we're going to do today is a cryotherapy skin procedure, but we're also going to open it up to questions for you guys, and we'd like to do that first before we really jump into the main event, because there's still people joining us that will want to see the actual procedure. Do you have questions for either Dr. Gawayne or for myself?
They're all looking at the comments.
They're looking at they're enjoying the comments.
Excited.
Yes, what's your
What's the what are the steps of this procedure?
Oh, the procedure that
Oh
we'll
yeah,
do.
we'll walk you through it.
You go ahead.
So this procedure is actually pretty easy. It's not going to be a really cool one like last time, I'm sorry. We were trying to make them grow some more of those little cysts, but
I'm working on one.
yeah. He is working on
I
it.
actually am. I'm not kidding. I do have one.
So it's a lot easier. It does not require prepping and opening the skin. It's actually
I'll get the
what
mic
we're
close.
using is, okay, that's too close, is liquid nitrogen, which actually destroys the skin and
Frostbite.
yeah, it gives you frostbite. So what we are doing is destroying the layer of the skin that produces this pre-cancer as we're going to be treating here. So cancers have a bunch of different stages. The ones we are going to be treating are called actinic keratoses, which are pre-cancers, which come before squamous cell cancers. So there's three major skin cancers. Do you guys know the names of all those?
Anyone?
Mr. Caminetti had told you one already, so you already, yeah, and that's the really bad one.
Yeah.
So melanoma. What are the other ones? I just said another one. Yeah, there you go. And then you can feel this keratin that it's producing when it becomes this precancerous state. And then once it turns into cancer, it starts to look really ugly. Fortunately, we're catching them early. Basal cell cancers is the next layer down, kind of the basal cell layer of the skin, and those produce a very typical appearing cell cancer. They're kind of domed appearing. Sometimes will grow their own blood supply and have little arteries within them, which is being.
Sometimes you can actually see the little
can.
vessels,
It's pretty
red
cool.
vessels on the
Yeah.
skin going up to a basal cell. Yeah.
And I actually removed 2 of those last week completely. I cured cancer. Thank you very much. So,
Some are easier than others.
yeah, these ones were easy. And then melanoma is the bad one, and you heard a lot about that. Yeah, melanoma is the one that likes to travel. That's why we do not like it, and it travels early. So it's kind of right on the basement membrane, and once it breaks through that barrier, it can go anywhere. It can get into your lymph supply, it can get into your blood supply, and go wherever those.
Likes to go to bone, likes to go to brain.
It does have some preferences. Yeah. So those are the three big ones. But melanoma is definitely the bad one. We want to make sure we get on all of it. That's why we took a silver dollar-sized area on Mr. Kimberly's scalp.
Yeah.
We're very, very sure that we're going to get it all.
And why he wears a hat.
Yes.
Like I do when I'm outside.
And why he's going to be checked every 3 months now. So
Yeah.
we catch those early.
So you're asking about the steps.
Oh, I didn't even answer your question. I kind of just went off on a tangent there. So not many steps. We
Prep the
fill out,
area.
yeah, prep the area by not really doing
There's
anything
no-
because it's not a sterile procedure. It's not like we need to clean it off. And then we'll fill this up. We'll kind of walk you through the whole thing. We fill up this little canister with liquid nitrogen. which is very, very cold. How cold is it? What's the negative?
370 degrees below zero.
That's cold.
That's its boiling point. So
Yeah. So we have liquid nitrogen. Okay. So it's really cold. And we shoot out the liquid. So it is that negative 370 degrees. And that creates frostbite. So we want to make sure that we don't freeze his whole head, just the areas that need to be treated. So we use a little adapter that shoots out a really fine stream.
instead of having the whole thing shoot out like a fire hose,
We'll show you how fire
it
hose
was very small tip.
Yeah, very small.
And I don't know if Kim
So
can
we can be
focus on that.
pretty. Frozen white color, and then we let
It
it.
just struck me, Rex, is doing this to me. Stop sweating.
Yeah, in another, what, 10 years, it's going to be me on the table. Your kids will be doing that.
I've never had this done.
Hope you know how many kids that are in this class in 10 years. All right, so, other questions? Did we answer that? Yeah. So we'll do 2 passes, make sure that just shows us that it's, that we really did get it. Oh, the healing process, how about that? So once we freeze this, nothing really happens for about a day or 2. And then that area that has been frostbitten will start to lift up off. That layer of skin will start to lift up off and it can blister, become red and irritated, and that those skin cells can slough off, and then it heals in essentially over the next week, sometimes 2 weeks, depending on how hard I hit it. We'll hit it.
I like the way you say that. So we usually do 2 freeze-thaw cycles. We freeze the lesion,
Get it all white. Make sure it's white for about 10 to 20 seconds. Closer to 20 is better. Let it thaw out.
We'll see what you're saying when
and
it's
then
going on.
Do it what?
I said we'll see what you're saying when
Well, it's
going
happening.
on.
It's,
10
I,
seconds, 10
I counted
seconds.
20.
What do you think, Papa?
Yeah, that's usually how it goes. So we don't tell patients, we just count in our heads, and that way they can't rush it. And I just did this procedure this morning to a patient and informed them I'm going to have this done to myself. Actually, twice. I did 2 patients this morning, at least 2. Did you do anybody today?
I didn't.
So very common procedure in family medicine, primary care medicine. Just to give you a little bit of definitions here, primary care medicine being that specialty of medicine that a patient would go to first before a specialist. It covers everything under medicine and surgery, if you divide the 2. Family medicine being specifically, well, not specific to anything. It's there. It's from cradle to grave. It's for some people delivering babies and doing obstetrics. Not for us, although you delivered babies in residency and got trained for it. Mm-hmm. Different from internal medicine, which is kind of the same thing, but without anybody under age 18 and no babies. And then some people would consider even obstetrics, gynecology, or gynecology to be primary care because a lot of women really are only doing things that have to do with the reproductive care, and so they'll just go to a gynecologist for their primary care, for everything. Okay, so do we want to, any other questions before we get to the main event? Wow, you guys are just waiting for this. Somebody fill me in, are there any, oh, you have a question?
When are we going to get to the main event?
Are there any really good comments on YouTube before we get started that we should respond to? Both? He always, oh, is it BooBoo? Is BooBoo up there?
Yeah.
Okay, all right. She's in upstate New York. Too well behaved? Yeah, they're used to.
Is that possible?
Yeah. BooBoo wanted us to do this thing where we have bow ties and cuffs and there's a dance to it, but I told her it's high school. What's BooBoo seeing? These kids are too well behaved. Oh, the kids are too well behaved. I thought she was talking about us. All right. So,
if people are getting bored, I guess we'll move on.
We need to start doing stuff.
So this is the doer. This is DEWER.
That's a high school joke, isn't it?
The doer is a vacuum surrounded container of so that we can't breathe or anything like that. It's harmless in small amounts, but if we filled the whole room with just nitrogen and no oxygen, we'd be in trouble. But just this little bit, we're okay. So do you want to fill?
Sure. So
Let me turn it around so they can hear you. Yeah.
So it's actually not even this high-tech device that pulls out the fluid. It's just this little, I don't know what you call it, spigot.
It's got a name, but I don't know.
It probably does.
With the heat sinks.
Yeah, so it has these, and this will
Trying
heat
to
up
get
the
warm.
fluid and kind of pull it up into the spigot. So we
So,
can,
little copper,
just
just
copper.
called heat sink. Purpose of them is to warm up the fluid deeper down, and if we seal it with a stopper,
gotta go somewhere.
it's going to, yeah.
We're going to go inside, not on my hand.
It warms up liquid nitrogen, increases the pressure inside, the pressure pushes liquid nitrogen up the straw, and yeah, we pull that out before we take it away, otherwise it would go all over the place.
Yep. And our mini doer.
It's kind of like a mini, a little thermos.
And this,
It even has a little safety
but
valve
it's
on
got
it.
a safety valve as well, so
Yeah,
we're
this-
not,
this
we're not
one is-
creating a bomb. Oh, if you turn it upside. So again, we're looking for these little.
Do you want me to lay
I'm gonna come
down,
over
or-
on the side. Actually, he's sitting up in the party.
Okay.
So these
Higher
are.
up, I'm up on the table.
What if I pass out?
You'd be perfect. I got it.
Yanni, have you ever had a patient pass out with cryo?
Not doing cryo. I have had a patient pass out giving a knee injection.
Yeah, I know, because he's right on the side of the wall from me. I heard him hit. I told him that the other day. Yeah, he came in. And we were in the same room. I said, "Yeah, I heard. I was right on the side of the wall. I heard you hit the wall." He was okay with that. Well, he didn't like it, but he was okay with the joke.
Came out.
He was okay with passing it out. Yeah, some people will pass out when they get needles put in them.
With the cryotherapy, will there be any tears?
Okay,
Yet
Mr.
to be
Schroeder wants to
determined.
know if there will be any tears with cryotherapy. Oftentimes there are. In fact, I think today I saw some tears when I was doing some cryotherapy, and it wasn't even on the person's ear. So it could happen. I'm nervous.
Yeah, so these precancer cells create keratin, and keratin is kind of this crusty material that you can feel on skin over some red areas. So you can usually feel these better than you can. Should we have them all come up and feel it one at a time? Precancer.
We could.
Some people are like,
Yeah, anybody who's
anybody wants to, can.
any of those who are like, I want to be a doctor, I want to be a nurse, or I want to be in medicine in some
You gotta
way.
get in on this. At least feel an activity.
Yeah, just go ahead and just go like that right there.
I'm pretty sure he showered.
Yeah, whoever wants to, come on up, so you can feel what one feels like. So the keratin is what's in just
is it?
right here. Keratin is what's in fingernails and
Oh yeah, there it is.
feel how it's kind of rough, almost scab-like, but it's not a scab. The cells are making this excessive amount of keratin. Sorry, and it's got that rough feel to it, almost compared to a wart. It's more of a sharp-like feeling. This is not a wart. There's no viruses. It's not contagious at all. Yeah. Good to see you, Delaney.
Me too.
Did you get a chance to?
Oh yeah.
So you have basically a fingernail growing out of your hand.
That's kind of what it's like. It's right here. It's just a little rough there.
Yeah.
Similar to these, but they're even more.
Did you feel the rough spot? Yeah. Yeah, go ahead. Okay, it was creepy for one. That could be, yeah. All right, this right there. So that's an AK, or actinic keratosis, and that's oftentimes when we're evaluating patient's skin.
So go home and check out your parents.
Yeah, and so
Feel any of these? Don't see their dogs.
common places are sun-exposed parts of the body, tops of the ears. So this is a very classic location. Temples, which I'll probably have one burned off my temples too, and bald people, old bald people, have them on their, sun is coming down on. Oh, I'm sorry. You didn't get to see it, Mr. Schroeder?
No, I did, right here.
You feel that?
Yeah.
That's now another thing we'll find, like in men that have beards and shave, oftentimes it can feel like that, or men who have hair grow out of their ears because they're old and hair grows out of their ears, and they shave the hair. It can actually feel very similar. So it's one of those things you kind of have to differentiate. Is it hair? Is it an actinic keratosis? Is it something else that's called a seborrheic keratosis? It's a lot like a wart that feels similar but doesn't quite have the sharpness to it. So everybody that wanted to feel an AK before it gets frozen felt it?
You got it all there.
Okay. All right, and I didn't start purring or...
Are you ready?
Okay.
Start purring. All right, so.
Oh, yeah, well, let's show both.
You
Let's
can
show
see-
with and without the...
Oh, yeah, let's take this off. So if we didn't have this nozzle to make the spray really fine, it would not be really fine. And it's a good way to scare your nurse as well. So
I stopped doing that.
I still do it.
I don't do it anymore. I used to do it to you all the time.
Yeah. Till I filed that law.
I know. Yeah, that was ugly.
All right, so are you ready? So we're gonna try to get at least 10 seconds here.
Oh,
Here, let's try to get this on video too. Ready, set, go.
Not as bad as I was expecting. Not as bad as that shot you gave me in the leather video.
All right.
Oh, come on
So
in,
hey,
Kim.
let's take a look at this.
Yeah.
Can you guys see that? Nobody on that side can.
So everybody's looking at the... is it still white?
Nope. It's thawed out already.
Oh, it's already thawed out. That was not nearly as bad.
Wasn't as bad as you thought it was gonna
So
be.
you've had multiple ones, you said? More than one?
Oh, we do have more than one. We'll have some on this side too. That
No,
we'll
I
do.
know.
I've
Oh, yes, he hadn't. This
I've
is his
never
first time
experienced
ever doing this.
Actually,
I've had warts removed, so I've
sometimes when
experienced this,
I'll
like,
hold
a
it
million.
and do it to a patient, because of the area it is, like maybe I'll hold their ear out so it just gets the ear and not the skin on the head, and I'll feel it on my finger, and it'll hurt worse than that did.
Hey, all right.
You're good.
I'm just good at this. All right, round two. Ding ding.
Okay, yeah, here, let Kim get within about a couple feet of it. Come on in and take a step. And
Right there.
yep, it bites a little bit. Jack Frost biting.
When you freeze it, it actually makes them stand out a little more.
Yeah, you can kind of see the
So now you can maybe
outline of it when you're
you'll all
freezing
be
them.
able to see it really.
In fact, sometimes I'll somewhat use that as a technique. Is it still thawing out?
It is.
Of where
It's
I'll
getting there quickly.
know roughly where it is because I felt it, but I cannot see it with my eyes. No, now I'm kind of feeling it. Wow. And spray a little bit of liquid nitrogen where I
We're gonna do
Okay.
this. Oh,
I'm sorry. Did I
the
miss you?
classroom's gonna catch it second hand.
There's one there.
Yeah.
Not anymore.
Won't be in.
In 10 seconds or 20 seconds. Okay, so it's thawing out.
I'm heating it up with my finger.
No, you're not supposed to.
I'm making the process faster.
You're not supposed to do that. I read that somewhere.
You read that somewhere?
I did. It said don't speed up the thawing out. Oh man, that'll get your attention.
It's a temple. That's got to be a sensitive area.
Yeah. Well, I thought the tip of the ear would have really been sensitive, and I
Somebody
surprised.
asked if a topical numbing cream would
Yeah.
make it less painful.
Yeah.
Well,
Or is it even worth doing?
yeah,
Is it that bad that you need to do it? That's
yeah.
the
I was gonna say
I
it's gone so quick.
now
I,
feel and time, yeah.
Yeah,
Or is it multiple?
doing it over years and years and years, and timing, doing a fairly consistent timing, and knowing how it's, you'll actually see different response to the freezing in different parts of the body with different thicknesses of keratin. Like, it's very different on the face from the bottom of a foot that has a lot of keratin.
Yep.
And oftentimes we'll use a different attachment than we have here today. When we're doing a foot, we'll use a probe and just touch it to it.
Yeah.
And this little offshoot here, all of the liquid nitrogen sprays out of that. It goes in and fills the probe and keeps the probe cold at the tip. And that way you're not spraying liquid all over. Yeah, you're able to get it deeper, especially with something that has a lot of keratin, because keratin's an insulator. And we want that cold to go in deep and kill those cells. Okay, any others?
I don't know, did you have any others? Any on your head? Head's a commonplace.
But I've been,
if you're not wearing your hat.
ever since I've started losing my hair, though, I've been really good about wearing a hat.
Yep.
So that's why you don't see a whole lot of stuff like sun damage up here like you do in my temples, which is why we encourage people to wear a wide-brimmed hat, which I didn't wear today, but
Yep.
I do
I think we're good.
when we go hiking. Okay, so let's have fun with liquid nitrogen and answer more questions. Any other questions while we're getting the liquid nitrogen going here?
Has anybody here had cryotherapy? Maybe frozen out?
Wart? Probably a wart, most likely. Yeah. Okay. Yeah, early 70s.
Wait, you don't even look older than 60.
Yeah, the old
Oh, yeah.
and some still use that.
Yeah.
Some still do that.
Yeah.
Yep.
Yep. Dr. Paul Thomas does it that way. Okay. So, yeah, you can just do that. You can pour some on the, well, let's pour some up here.
What shall we do? Yeah, actually, it evaporates.
So it's a
almost instantly.
evaporates very quickly. It's a colorless, odorless liquid. You're smoking. That's pretty good.
Wrong level. You shorter people.
We won't give away Dr. Janice's trick that he always does.
Yes, yeah. If any of you have Janice.
Yeah.
You get to play with some of this too.
No, we're not drinking. It can be used to make ice cream. It can, we can pour it into your thermos to instantly cool your drink. Do you want it? Do you want it really, really cold?
It'll evaporate pretty
Okay.
instantly.
Also, we can show exactly what's going on when it comes out of the dewar by just having it go straight out onto the little shower of it there. And it's kind of neat for the Halloween effect with the, but it goes away really quick. Those of you in the front, can you feel it? Yeah. Can you feel it? It's going right down to the floor and just going around, and it's, let me see, I'm getting a little bit of liquid on my pants, but not much. Not enough to cause frostbite or anything dangerous. And then, a rose. Anybody have a rose they don't want to keep? No. Finger? No. You don't want to keep your finger? Okay, so other things that we usually talk about. Mr. Schroeder, I'm trying to remember other things that we usually hit when we come and talk to your class.
They had a few questions that we've got.
More questions. Okay.
Is that okay?
Yes, we want to do questions. We want questions.
So over the course of
can I ask you to step out of the way of the camera? Thank you. Because sometimes we use that shot. Yeah. It's our wide shot there. We switch back and forth.
So we've got skeletal system, we've got muscular system, we've covered epithelial tissue and cancer.
Okay, so the question is, for people who are flat-footed, since we have this renewal of cells over time, why doesn't it correct?
Yes.
And the reason it doesn't correct is because the osteoclasts that create the bone matrix still have the same DNA. And although you do have renewal of the cells, the bone matrix itself is very, very slow at renewal. Evidenced by, if you see x-rays over time of a broken bone, in kids, they correct within a few years and you can't see where it was. As people get older, you can still see where it was. There's not enough turnover to really do that. That would be my explanation. Would you have a different explanation?
No, genetics play a big role in flat feet, unfortunately. So,
Yeah.
you take bad parents. Sorry.
Yeah. But flat feet will not keep you from highlining in Yosemite or doing very well at American Ninja Warrior, we found.
Proper footwear is the key.
Yeah. Oh, waiting for another question.
Ethan asked about some of the knees in snowboarding.
Knees in snowboarding would be an Ethan. That would be an Ethan question, wouldn't it? Thankfully, it hasn't been as relevant as ankles recently. What specifically about knees in snowboarding?
I think when we're talking about how
I have no idea. Okay. We can make up a question. Why are ACL tears so common with snowboarding?
Why are ACL tears so common with snowboarding?
What do you want me to answer? So ACL tears happen when there is a forward, what would that be, impact on usually a flex knee.
You want to demonstrate on mine?
So it happens often in soccer, football, when you get shot block. And unfortunately, it happens fairly frequently when you're snowboarding because your foot is not going to move. It's strapped in. So it's, and that's holding essentially your whole lower leg in place. So while you're moving forward, your feet aren't always moving forward along with your lower legs, and you can just get that forward shearing force and rupture of the
So it would be
ACL.
a stopping of the snowboard, a continuation of the inertia of your body.
Mm-hmm. Yeah.
All right.
Yeah.
Bummer.
Yeah. They're especially common in soccer. Soccer's like bad for you. Don't do soccer. No, just kidding. Yeah, no. And even worse in females who play soccer. Sorry.
But what's it
that is
even
the
when
most common.
they collide, or is it from
Yeah,
hitting
so
the
it's
ground?
a planted foot.
Right.
Yeah, with somebody usually sliding in, trying to
Yeah.
hit the ball that you're kicking. So
Yeah. All right. So how would you test for stability of the ACL?
Oh yeah, sure. It's probably gonna be best if you're. So there's a couple different ways to check for an ACL tear. The most sensitive, you guys probably don't know statistics, but sensitivity means the one that you're going to find it the most often, is a Lockman's test. So you get the.
Should I show the knee?
Oh yeah, there's a knee under
Should I
there.
show some leg?
Whoa. So
It's hairy.
there's that, and then the anterior drawer test. So the Lockman test, you get
No,
the
put this
leg at about 15 degrees here, or 75 degrees, whichever way you're looking at it, and you support it. It's hard to do when I'm not sitting on my chair. So you support it, and then you support the top leg between the table and your hand. You grab the tibia,
And you want the patient to relax so you
and
can,
you say, relax.
so that their muscles
Relax.
aren't
And then
holding
while
it in
you're-
place.
Yeah, while you're talking to them and distracting, you pull. No, yeah, but what you do is you pull, and if you have an ACL tear, there's actually a little give, and
Yeah.
you don't have that ACL to hold your leg in place.
Yeah.
So that's the Lockman's test. Another one is the anterior drawer test, which is the same, where you're pulling forward, but not as sensitive, not as you can't find them as well.
So anytime we have somebody come up with a knee injury or knee pain, that'll be part of our knee examination, is checking that along with all the other ligaments and other tests that we do similar to that.
Yeah, musculoskeletal stuff is really fun. Really cool.
Yeah.
Yeah.
There's an anterior drawer test on your ankle as well, right?
There is, yes.
There is an
Yeah,
anterior
so
drawer test on the ankle.
You're
Let's
testing
show
the
that.
outer ligaments. You don't have the internal ligaments in the ankle. They're all outer. So you're actually testing those ligaments. And it's the same thing. You support the upper above the joint and then grab below the joint behind and pull forward.
Mine's pretty loose, huh?
No, you're good.
Oh, all right.
Have you rolled that ankle?
Felt like you really moved it.
Usually you compare it to the other side. So some people
Yeah.
are like, hey, whoa, and then you compare it to the other
Yeah.
side and it's normal.
Okay, other questions? or really good comments, or
Nice leg.
Guy in front row in green shirt.
I think it's Connor, yeah.
All right.
The last question that we have is how you fix carpal tunnel.
how do you fix carpal tunnel?
Okay.
Fix.
So first of all, we gotta know what carpal tunnel is. Does everyone know what carpal tunnel is? You guys talked about it.
We're talking a little bit.
Some more than others.
Go ahead, I'll let you know.
Oh, okay. So we'll talk about carpal tunnel syndrome.
You can do your test.
Syndrome being any kind of collection of signs and symptoms that go together, usually from a common cause. And in carpal tunnel syndrome, we're concerned about, usually a complaint of the symptoms will be starting at night or when holding on to stuff and gripping it, getting a numbness in the hand. Usually it's actually this side of the hand, the thumb, the first two fingers here. And it'll be on the palm side of them, not back here. Carrying bags, doing upholstery work where you're wrapping the leather around whatever. These kind of jobs often, and it's usually associated with a job or a lot of activity with the hands, will cause there to be a lot of swelling in the tendons through what we call the carpal tunnel here, which is some bones in a crescent shape. If you consider a cross section of this, the bones are going along like this, and then you've got a band across here, the carpal tunnel ligament, and you've got lots of tendons in here, and there's a nerve through there, the median nerve that serves sensation of this part of the hand, including the medial, or actually radial half. When I say radial, I mean thumb side. Radial half of this finger. So when we're doing exams on people's fingers or on their hands and checking their nerves, we will check sensation on this side compared to this side. And this will be the same as over here, and this will be the same as over here because of the way the nerves serve it. So median nerve here, radial nerve here, and ulnar nerve here. They'll also lose strength too, because some of the muscles for finger flexion are affected that are in the hand that actually get served by that nerve. So we'll do some tests. I demonstrate on you, huh?
Yep.
So we'll do a couple of tests to try to see, is this really the nerves? First of all, we'll check sensation, we'll check strength, and strength with the median nerve would be, let's see, this would be radial nerve, this would be ulnar. What am I missing? Okay, so pincer grasp, you put a piece of paper between their fingers and you try to pull it away, and if it just slips right through, there's some weakness. If they can hold on to it or the paper rips, you know you got some strength there. Maybe compare it to the other side. You also want to have some finger flexion there. And he can hold on. You do it with two fingers and they can grab on pretty well, and usually they don't hurt you. Usually. Some people try to, and if you do it with just one finger, they can really yank on that one finger and pop it. If you do two, usually it's not going to be a problem. Yeah, I'm not going to give you a chance to do that again. So another thing that we'll do is we'll tap right on the carpal ligament there as the median nerve comes through and see if it recreates the symptoms. See if they start having that tingly sensation or pain with hitting there that they feel up here. Another thing we'll do is the phalanx. Yep. I looked at him to remind me of everything. It was 12 years more recent that he was in medical school, where we put the wrist in a right angle there and hold it there for a good 30 to 60 minutes and see if that recreates the symptoms, because that'd be a long visit. 30, 60 seconds to see if that starts to recreate the very symptoms. Am I missing any tests for carpal tunnel?
No, those are the two.
Okay, so then if they've got bad carpal tunnel, we'll go ahead and put them in some kind of you're doing it right now? Check it. We'll put them in a splint called a cock-up wrist splint, because it kind of cocks the wrist back like that. Not really, though, because actually this is the neutral position, what we call the anatomically neutral position, or the Coke can position, as opposed to this. Can you see the difference there from there to there? That is actually flexed a little bit. It's not neutral. This is neutral. And this position allows that little tunnel there, the carpal tunnel, to be open, whereas here it's rather closed. And you put your hands there and you move back and forth, you kind of get the idea of what's going on there. Put them in the cock-up wrist splint, and this will help to protect the integrity of that space there. Then you have them wear it at night, you have them wear it when they're doing activity. And if that takes care of the symptoms, together with some anti-inflammatory medicines like ibuprofen-type medicines, if they're able to take that, oftentimes that'll help minor symptoms. Or finding out what the activity is and having them do it differently. Instead of having their hands like this on the keyboard, having it straighter like this. You know, that's something keyboard typing can be, or mouse. Maybe not having a mouse, maybe having a trackball or something instead. Of course, that can cause thumb joint issues. Then if that's not doing it, we'll probably next step get actual nerve conduction studies where we time how fast nerve impulses take by putting a probe at one place that shoots a little electrical shock, another one on the other side of whatever you're testing here for the carpal tunnel, to see how fast the nerve impulse actually times how fast it takes for that electrical impulse to get through. And it'll be delayed if there's some injury to the myelin sheath. You guys remember myelin sheaths? Yeah. Okay, what's their job?
Saltatory conduction, remember that term?
Doesn't it speed up the nerve impulses?
That's right. So if the myelin sheath is injured, there's going to be some slowing there, and you can actually measure that slowing. And they'll measure it to make sure it is indeed there, to differentiate a problem with the nerve here causing symptoms from a nerve here causing, or here, or here.
I was scratching that.
Oh, okay. I was going to say probably not, but then if we're just not making any improvement, it's really impairing the person's life to not be able to use their hand and they're having pain. The next step would be to actually have an orthopedic surgeon or hand surgeon, who's also an orthopedic surgeon, cut this band, the carpal tunnel ligament, just snip it, and then that pressure's gone. Takes all the pressure off of the nerve.
Yep.
So when I was in college, I had that, and the doctor recommended doing like a paraffin bath. Do you remember that?
When LeeAnn was in college, she had some symptoms that had some similarity to carpal tunnel, and they recommended a paraffin bath. You guys know what paraffin wax is? It's a paraffin bath. You put your hand into the wax and pull it out, and you've got a wax glove on your hand. Very hot, and that's actually more for arthritis symptoms rather than for the carpal tunnel. They were working out what really was going on, and that was for, well, maybe it's arthritis, and maybe this will make it feel better. Did it make it feel better? No. It was just very hot. It's fun to play with, though, because you kind of peel this wax off your hand.
You have a question from the med heads?
Yeah, you have a question.
The med heads.
BooBoo Kitty.
It was a BooBoo.
Well, someone above the
Tell them how the pain goes up the arm and into the shoulder. Okay, pain going up the arm and into the shoulder from carpal tunnel syndrome is from something else going on, not the carpal tunnel. So that would be another issue, and that'd have to be worked up. And that's actually, thank you, BooBoo. That's a good point. That oftentimes when people come in and we're working on whatever a problem is, and it kind of looks like carpal tunnel, oftentimes there'll be some complicating factors, or the picture will not be totally clear like it is in the textbook. It'll be a little difficult to interpret, and that makes our job a little more difficult. It makes it a little more interesting, too, because it's not just cookbook straight out of the textbook, this is the problem, here's your prescription, go home. It's scratching your head and talking to your colleague and talking to the specialist and trying to work out, well, why is this person who really looks like they have carpal tunnel syndrome also having symptoms up their arm and in their shoulder? And of course, getting the nerve conduction studies will help with that. A lot of times patients will want an MRI. Give me an MRI. I want an MRI. For some reason, they think that's the cure-all to everything. Actually, MRI doesn't cure anything. And in the case of something like carpal tunnel, when we're trying to track down where the problem is, imaging is not going to show you. It may show you some inflammation and swelling in the carpal ligament, but really it's the nerve conduction test that costs a lot less money that's going to tell you where the delay is. Okay, there you go.
Oh, yeah, so they were talking about the Bonesberg question. They had a question about some type of cyst or whatever they're commenting up there.
Oh, yeah.
Letting you know. So I don't know. It was about Baker's cyst or
Baker's cysts are, or popliteal cysts are a cyst from a joint, and it's behind the knee. A little bit of joint fluid will get out into that space, and it's continuous with the knee, but it's got a capsule around it. And they can be painful, they can cause swelling, both locally where they're located, but also down the leg you can cause swelling because they can compress the veins that empty the fluid from the knee and let it go back up to the rest of the body. oftentimes they're taken care of in surgery. I think in the old days they would aspirate them or stick a needle and just suck the fluid out. But I believe that's fallen out of favor because it is continuous with the knee joint.
Yep.
And they, if you were to get an infection from doing that, it would be bad. So they actually cut it out in the operating room. Mm-hmm. Yeah. I was going to look to see. Man, BooBoo's going crazy up there.
Where's BooBoo? I'll answer your question.
She's in New York.
Hot flashes and sweaty.
Hot flashes after
Because a lot of people, like even
blood donation.
myself, I experienced that after donating today, and a lot of people were just getting extremely hot. And
Yeah, a lot of people, but not everybody. So the feeling of getting hot and flushed, maybe sweating, maybe a little lightheaded, maybe even nauseated for some people after blood donation. When you have something happen to you where there's some pain, and there is some pain with blood donation, some nerves are stimulated inside of you that normally don't get stimulated, this specifically being pain receptors deep in the arm here under the skin. They'll trigger something called a vasovagal episode. Have you guys talked about that in class? Or? Okay. The vagus nerve.
Cranial nerve's coming up still.
Yes, vagus nerve, cranial nerve number 10. It's a nerve that comes from the brain and goes down into the thorax and even the abdomen and stimulates lots of parts of your innards. And when it gets a general discharge, which it will in response to sometimes something that's surprising or disturbing emotionally or stimulation of some nerves. Some people it can even happen just watching somebody else get their blood drawn. When it goes off, it will cause the heart to slow. It will cause blood vessels to dilate. That's why you feel hot. It'll stimulate the sweat, and people sometimes can pass out from it. It's what we would call the classic faint. It's a discharge of the vagus nerve, and it's kind of in some ways a maladaptive response. I'm not quite sure if there's a real good evolutionary explanation for why do we have vasovagals. Maybe our ICU nurse would have any.
I don't know, but we always watch people when they use the bathroom.
Yeah.
That's where they
Yes.
basically-
Bearing down,
Micturition syncope. Yeah, that's right. People will have to use some muscles to be able to go to the bathroom when they get old and their systems don't work, and sometimes they actually will pass out.
It happens more often after you give blood because you have less blood in your system.
Yes.
So as soon as you have that even mild dilation of the vessels, you don't have all the blood to fill that up and occupy that space. So usually you're standing up or sitting up. What's the first place that's going to drain a little? Up here, and the best thing to do is your body says, okay, I'm going to pass out so I can get everything level so I can get blood back to the head, right? So that's why we have that there.
Oh, a better explanation than I had.
Get down low.
Yes.
Yep.
Yes. Yes, the passing out while going to the bathroom or stroking because of bearing down and pushing and so it increases pressure in the cerebral vessels is why the king died on the throne.
No one else caught that.
The king. The king. Yeah. Also, I believe it was Leonid. Wait, Leonid? Lenin. What was Lenin's first name? Lenin. I believe Lenin also. No, it wasn't Lenin. I'm sorry. It was Stalin. Stalin stroked on the toilet, and he had everybody so scared that I believe it was many hours, if not a day, before somebody actually found him because nobody wanted to disturb him while he was in there because he was killing everybody. Yeah.
Just being considerate.
Okay, enough politics and history here. Other questions? Yeah, we're just being considerate. Yeah.
I kind of had kind of like a wondering question because I know a lot of mainly girl students at the blood drive have been turned away because they have low iron.
Low iron.
And I know the blood techs were saying something about it just takes longer, especially for girls under a certain age to replenish that iron. Why is that?
People who are menstruating is usually who it is because you're losing blood monthly, whereas the boys,
So all the
we don't do
guys
enough
who are
bloodletting on them.
menstruating, They were turned away too.
Yeah, that's really the way it is. You're right. Any boy who's menstruating is more likely to get turned away. But as far as that test they do with the iron, I've always wondered about that, and maybe you have some input on this. I don't think it is a hematocrit, though.
I thought they
They
did the spinning
insist that it's an iron test,
It's
not a
not
hematocrit. You're saying it's a hematocrit.
I think,
Where they
yeah,
drop,
I think it's just a hematocrit. That's
where they drop the thing in the water. You were talking about
I'm
spinning a
talking about
hematocrit.
spinning.
Are they spinning a
No,
little
It's the copper sulfate.
copper sulfate?
It's a density test.
A
okay.
density test. It is iron.
It's an iron.
It is not a hematocrit that,
I'm on. I was
that
wrong.
you would think it would be.
They can do
So-
hematocrit, if they really want to test it, like at a blood center, they'll run it
They'll
with
spin it,
hematocrit,
yeah.
So-
spin it down, but it's just a density test.
So,
If there's enough iron.
yeah, yeah.
They
So,
pick the right test.
so generally that's going to pick up
Yep.
any kind of anemia because
Sensitive test.
all
Again,
all blood, all blood has
Uh-oh.
iron in it. Okay, next. What? Yes.
So why, another like giving blood question, I've had a friend who had like very, very mild eczema on their arm and they were not able to donate because of that.
I talked to them.
Okay.
I believe the situation would be that the people who are doing the donations would not draw blood from anybody with any kind of rash where they normally go in. They're not really in a place to diagnose what the rash is, and if it's a possibility that there's either a fungal or a bacterial infection and they introduce that into the bloodstream and cause sepsis, that would be really bad. So they just have a blanket rule of any rash, we're not going through, you can donate blood when your rash is gone. I would guess that that's what's going on. And Mr. Schroeder says that's what's
Yep,
going on.
That's always
So,
where it is for eczema.
and unfortunately, eczema is off. Yes. Okay, that was a good one.
You talked before about, and if you wouldn't mind just talking a little bit, some of these students are thinking about medicine as a career. Some of them, should go into what area of medicine, whether it's a doctor, nurse, PA.
I know somebody wrote a great blog post.
I think it was a great blog post, yes.
Oh, yeah, shameless plug on my blog post.
Dr. Green,
Because originally, I know, Wayne, you mentioned that
Yeah,
your
yeah.
uncle was doing it, and so that was kind of an inspiration.
Yeah. And ours were different. I went into family medicine. Dr. Mark went into emergency medicine. We had much different experiences. This is my blog, in case you want to check it out. That'll be required reading.
required reading, drgreenknight.com.
Yep. So, Dr. Green Knight, anybody can guess why I picked the name? Any English? No, actually, Sir Gawayne and the Green Knight. Anyone? Boy, you guys need some English classes. All right. Sir Gawayne and the Green Knight. But anyways, drgreenknight.com. Check it out. But yeah, I have a nice little blog post on why I went the way I did. But emergency medicine. Why did you choose emergency
I
medicine?
chose emergency medicine because I thought
Before that, what made you decide medicine and then?
medicine.
Oh, yeah, mine's different.
Okay, I was LeeAnn right over here, who's now my wife. Back then she was my girlfriend. Our second year of college. I was a broadcasting major, loved it, had a blast. Came into college with some credits because I did something that would be kind of similar to what AP is now. So I had a little bit of room to spare. So I was able to just kill it taking the higher level classes, even though I was just starting out. And I did a few at Sierra too before I got there. So even as a second year student, I'd already done everything I wanted to do. I'd been on television, been on the radio, taken the multi-track recording class, all the really cool stuff in the media courses. LeeAnn had a cousin who was at our college who was pre-med, and I remember it just hitting me, pre-med, that is the coolest. He's going to be a doctor. I would love to be a doctor. I always thought that was cool. The only reason I never pursued it was because when I did my aptitude test at E.V. Kane, it told me if I only wanted to take 4 years of college, being a doctor was not what I wanted to do. But now that I was in college and I loved my classes when they're about stuff you're interested in, I thought this would be the greatest thing. I'd be able to take classes that are about the human body and how it works and how we treat it with medicines and how disease hurts it. I thought that was just the most intriguing thing. And so I realized I should be a doctor. I felt like God called me to be a doctor in that conversation we were having. She was just kind of a sounding board for me. Went in the next day, sold back my books, bought all new books, got all the classes, and thankfully was able to get out of college on time and get into medical school the following fall after my fourth year of college, which took really slamming some things together, because to get into medical school, you have to hit certain things. You have to be able to take general chemistry, and then after that, take organic chemistry, But take them both enough or early enough that in the end of your junior year, you can take the MCAT and have all that knowledge fresh and have had it, so that during the 4th year, you can interview at medical schools so that you can start after you graduate from college. Sound similar to your experience? Except you started out.
Yes, I did.
You started out pre-med, so you didn't have all that cramming things together,
Wasn't as tight.
taking calculus and calculus-based physics and organic chemistry all together at the same time, along with human physiology.
Yeah.
So it took a little bit of sticking things together. And then jumping ahead to choice of residency, I loved procedures. I loved watching Emergency. Remember Emergency as a kid? BooBoo, I'm sure you loved Emergency too.
Yeah, right?
And then in medical school, it was a show called ER that I loved watching with Noah Wiley, who played a 3rd-year medical student, the first year of the show, which was when I was a 3rd-year medical student. And then as he went through, I also went through and got into emergency medicine residency. I don't know if the character did emergency medicine residency. He may have done surgery, but following that pattern of the excitement of emergency medicine procedures, which was really cool until about 2 years after residency and doing it and working in the emergency department in Roseville and Sacramento, nights and weekends and holidays, and leaving my family when they all got together at Easter because I had to go start a shift. I wanted the 9-to-5 life, and thankfully eventually was able to get into having a family medicine office, which I was able to kind of translate my education and training and experience in emergency medicine to family medicine without much difficulty, which actually I need to give some credit to the folks at Sierra Doctors Medical Group, because that's where I kind of did my on-the-job residency, or not for real residency, in primary care, and learned it right here in Auburn. But you went straight to family medicine.
I did, yeah. So I did that in writing. That's where my residency was. Family medicine is a 3-year residency. So like I said, I wanted to do everything. That's why I chose family medicine. I enjoyed procedures too, and you do get to do a lot of procedures. And I wanted to get out and start working. So 3 years was like, hey, I could get going.
Short residency,
and
not surgery.
Minimal call. That's another one that I wanted, because I don't like being on call.
Yeah.
Some people really enjoy that. Some people do thrive in that shift work environment. They're called ER doctors.
Hospitalists.
Hospitalists. And if that's you, great. It's everybody has their own thing to do. Or
Okay.
their inappropriate things.
What's so good? What's
Donald Trump or Donald Trump is
the one above it?
yes, Claire, you want to do that.
Oh, Claire.
You can go to the bathroom.
Claire, wait. I think they're talking about you with the professor, Donald Trump.
Professor.
I think. Yeah. Is it gone now? What a great professor to have. Great job with this initiative. So great.
So great.
So great. So great.
Thank you.
Thank you, Donald Trump. And for those watching this after the fact, when we keep talking about Donald Trump, it's because somebody commenting calls themselves Donald Trump on the. What?
Is it the real Donald?
No, that's on Twitter.
I hope
That's right.
he's not watching.
Yeah, there's 2 different ones. One's on YouTube, one's on Twitter.
So do we have anybody who's interested in the medical field? I'm just curious.
Wow!
Hey, all right.
Wow! But that makes sense in an anatomy and physiology class. There'd be a lot of
We didn't
people
have
interested.
this class while I was here, so I was
No, me neither.
Fortunate in you guys. But
Yeah.
I did have Mr. Schroeder as my teacher for biology.
Yeah.
Second half, I think, right? Second
Yep.
term?
Yeah. And you would not believe how close I was to having Mr. Schroeder. Your first year here was 89. He came the year after I graduated. I totally would have been in this class with him, just a year off. Yeah. All right, other questions? Yes?
Next semester, I'm going to be taking an EMR class for Sierra College. It's like an ROP class. So what kind of things should I expect from that?
Okay, so you're going to be taking an EMR class through ROP, which is occupational training at Sierra College. You said EMR, like electronic medical record EMR? Oh, emergency, but they don't call it EMS?
Like
or EMT? Oh, okay.
paramedic. Yeah.
Okay, so So first of all, congratulations for getting in, because our daughter Kara was not able to get into the program because of timing. They will have you do really less theoretical, although there'll be some theory to it compared to what a doctor gets, and a lot of real practical, like training in CPR, training in first aid, initial wound care. What else are they going to give her?
All the first responder stuff.
But not the stuff
all
that a
the
paramedic
orthopedics,
gets necessarily.
bracing, probably.
Yeah, the splinting,
At least until you get to hospital. All the pre-hospital stuff.
blood drawing, possibly some
Maybe more of a
administration of
paramedic
medicines.
thing. Yeah, I think that's more paramedic, which is the next.
Starting IVs, yes, starting IVs. That's right, yeah. But it'll be neat. And what will be really fun is going out on calls if you get to do ride-alongs.
It'll be even more fun when you practice like
Yeah, riding in an ambulance with the sirens going through intersections with the red light. And that's fun to do. I got to do that as part of my emergency medicine residency. One of my rotations was EMS, so it was riding along with the ambulance. It was flying in the helicopter. It was, well, the entire time we would take turns being the base station medical director. So we would take the calls from the EMS or the ambulance or the paramedics to tell them what to do in certain cases when they're out in the field and they came up with something where they needed some direction or that was outside of what was covered with their normal protocols. Okay, other questions, either here or there, either one.
There we go.
Yes, yes.
I don't know if this is something you have an answer for, but for forensics pathology, going into that, what kind of, do you know, like, is that the same kind of medical school that you have to go through?
So forensics pathology.
Yeah, so I'm pretty sure that is a pathologist who does that. So, yes, you do. Sorry, you got to learn all the other stuff too, but that all does form a basis. So a pathologist can become a forensic pathologist and look at all the different stuff that comes in for a case. But pathology is a 5-year residency. Yeah. I think they do 1 year in internal medicine and then 4 years beyond that in pathology. And that's beyond your 4 years of medical school.
4 or 5 year residency.
Yeah. Lots of time behind a microscope. I hope you enjoy that.
Yeah. I would probably have some specialists not like me saying this, and go ahead, please send the hate comments. We're glad to have them. Just makes my channel more popular. The radiologists and pathologists, they, for the most part, not as much now, but for the most part, don't have direct patient contact. And there's some people who want to go into medicine, want to go to medical school, but they really don't thrive on having a relationship with other people. And the field of radiology or pathology is great for them because they don't have patients that they interact with that are alive.
We're not saying you're like that. We're not saying...
No. I'm just...
So
maybe you are. I
loners
don't know.
become that.
I had a friend who went into emergency medicine, and a lot of times emergency medicine is emergency medicine, family medicine, because they're both 3-year, and there's a lot of similarity between them. And one of my friends who chose emergency medicine, we were talking about this very thing. Do I want to do family medicine? Do I want to do emergency medicine? And family medicine, you develop a relationship with your patients, and you follow them over time. And he said, you know what, I don't go to work or want to be going to work in medicine to get my friends. I have my friends, and the patients are the patients at work. And so this is obviously a person that relationship over time with the human being you're taking care of did not mean as much to him as it did to the people who did family medicine.
Imagine you're an introvert. Would I be correct in saying that?
A little bit, yeah.
A little bit?
Okay.
So here's the cool thing about medicine and just being a doctor. There's a place for everyone, all right? Like anybody could find a place in medicine. So the shyest introvert can find a place, usually as a radiologist or a pathologist, where they're just looking at stuff all day.
In a dark room.
ER where you're seeing multiple patients at once. You could be the huge extrovert. People who are very good at managing multiple things at once. Not me. I have to do one thing at a time. That's why I see one patient at a time in an office.
That's
so
nice.
so that's the cool thing. You will find something if you go into medicine and just look for what you'll find it.
That's the cool thing about medical school and nursing school.
Yeah.
Is you get to go and you do rotations in all the different
Yes.
areas, and so you get an idea real quick whether or not it's your area or not.
Kim points out that it's fun in both medical school and nursing school. I'm repeating this for the people on, because you get to do all the different rotations through all the specialties. And you don't have to know when you go in, because you can try different things and see what you do like and where you thrive and what really turns you on, and where you seem to do a better job just naturally with your talents compared to others. Yes?
Wait, so you worked in emergency medicine, right?
Yes.
So you know the show Untold Stories of the ER?
No, he does.
From your time in the emergency medical, what are some of like the really weird or like really like scary stories that you have from there?
Scary. Halloween's coming up. What are our scary clinical stories?
Check out drgreenknight.com.
Do you have one?
There are some pretty cool stories. Actually, my intro post actually has a pretty cool story if you want to check that
Oh,
one.
that's right. Yeah, that one.
Just go to the.
Yeah. drgreenknight.com does have his story.
I like
one of the ones I usually go back to, well, there's several. I'll try to just give brief little snippets into a few of them, and if you guys sometime outside of class want to have more gory details or whatever, we can talk about further. But one would be intubating a patient, putting an airway through their mouth into their esophagus, and this is after a motor vehicle accident, and seeing through here, above the nose, below the eyes, looking through here where there was an injury, and looking into the back of the throat through here, seeing what I was doing. That was kind of interesting. Really not good for the poor person, though. Another one would be, what was I going to say? There was another. Have I told you anyone? I'm trying to think of one that was, rectal foreign bodies are always interesting. Won't get more into that other than to say that wedding candles are usually that big around. Another one would be, seeing somebody get a shot right through their clothes. We had one patient who was so agitated and dangerous to himself and all those around him. It was drug related. And I remember techs and nurses all grabbing, an arm or a leg, and somebody just coming with the Ativan and just right through the pants. Yeah, it was necessary. That was pretty cool, though. And you see that sort of thing in emergency medicine. My rotation in Papua New Guinea was pretty cool. The Nazarene Church has a hospital in Papua New Guinea in the Western Highlands. This is about as remote and as primitive of medicine as you're going to find, although it wasn't all that primitive. They actually have a hospital, it has quite a few services, and got to see tribal warfare, people coming in with arrows sticking in the neck, and the one guy that or woman I was trying to resuscitate, it was interesting because they said, she fell out of a tree, because they would speak a language that the people in the hospital and I knew, English, but then having the people in the hospital staff that know some of the more different languages. And when you want to know something about languages, look up Papua New Guinean languages and see. It's just amazing. A significant number of the language of the whole world are on just that one little island. But somebody knew the same language and passed on to me, no, her husband killed her. Yeah, which is another thing that happens in Papua New Guinea, that sister wives thing is not rated for the same television audience that it is here in America. They need some of that there. What was the other one you were saying? I was going to say, you talked about forensic pathology, forensic psychiatry. One of my rotations in medical school was forensic psychiatry, where I worked under John Rabin, he himself had worked under Park Dietz, and anybody who knows the new series on Netflix, Mindhunter, I believe it's called. Yes. Okay, that's about Park Dietz. And so these, for example, one of my experiences in that rotation was having lunch across the table from a man who murdered his family, and talking to other people who did similar things and trying to understand them. And of course, Park Dietz is all about the profiling these people so we can understand what kind of a person does this sort of thing so we can go after. Okay, you guys are all smiling. What is it?
Donald Trump discourse in the comments section.
He what?
Donald Trump discourse in the comments
Donald Trump is having his discourses. Oh my goodness. Ethan, can you just make him go? Or no, not Ethan. It would have to be, I'd have to be logged in to do it. Okay. Yeah, no, we're not. Okay, we'll just ignore him then. Other questions or?
Psych is extremely interesting.
Psychiatry is.
Yeah, the VA is a very interesting place for psychiatry too. There's a lot.
Yeah.
You work at VA, right?
Yeah.
So in Loma Linda they have a VA psych ward. It is a lockdown ward, and I remember similar things talking to people who were talking, who had gone through Vietnam and other things, and talking about how they killed people in graphic detail. While I was having a conversation with one guy about that, another one came up and just decided it'd be cool to urinate next to me, so that happened.
Was I the first?
But all sorts of cool stuff. Psychiatry is really interesting the way the brain can go awry. I mean, you can get people so out there that they can't put sentences together, that they're just putting together what we call a word salad, where the words are just all over the place.
Yeah.
They'll go down rabbit holes that make no sense, but to them it somehow does. And the great thing is when you actually get them controlled on medication, how well they can do. It's actually, the medication we have for psychiatry is pretty neat.
And also, after psychiatry, you look at the world differently. If you watch a documentary on, well, there was one on prefrontal lobotomy. I don't know if anybody caught that talked about the Phineas Gage story. I'm trying to remember who made it, but I think it was called maybe it's just a YouTube video, the most inappropriate Nobel Prize, and it was because somebody got the Nobel Prize for frontal lobotomy. And it really demonized the people who did this procedure, and the procedure itself completely across the board, which may be appropriate. But I also thought about how people do that to electroconvulsive therapy, or shock therapy as it's called. Saying, oh, what a barbaric thing. How could a psychiatrist do that to a human being? That's such a barbaric thing to run a electrical current through their brain for the very purpose of damaging part of it so that they change in some way. And you would think that until you've seen it. Until you've seen a person who for months or longer does not want to live. Any chance they get, they try to kill themselves because of the pain of existing and living. They do not want to live. They do not have anything. They do not have enough care for their loved ones to stick around for them. They just can't see beyond this wanting to die. And then have electroconvulsive therapy done, which, by the way, when it's done, they are unconscious and, in fact, even anesthetized to the point that they don't move at all. The only way you know that's happening is because of monitoring their brain waves, and you see the shocks that indicate that they're having a seizure, which is actually the goal of it. And then when they wake up, they're not suicidal and they can go home and live a life. That's an interesting thing with psychiatry, to see something like that. Yes?
Does that always work, or are there some times like
No, it does not always work. No.
It's actually pretty good, though. It's got a pretty
And it's not something to jump to.
Yeah, no.
I mean, there's lots and lots and lots of steps before something like that is considered. I mean, it's a situation where when you totally understand what you're doing to the person, you would still choose to do it. It's that bad of a situation where it should be used. Not to say it hasn't been abused or used freely by some people in the past, but in my training and when I witnessed it, it was in that sort of environment of a person who this is it. If this doesn't do it, this person's not going to be with us much longer.
Well, we got about 2 minutes, so before any last questions, I just want to say again, thank you so much to your entire team, both of you and
Yes, thank you, Kim Crone, for
thank you so much.
and LeeAnn and Ethan. Thank you, guys.
Really appreciate you taking the extra time to come out here. It's been great having you. And,
Always fun.
that flew by. I can't believe it.
I love doing it in person.
Yeah, it's good.
Yeah, yeah. So I guess, can you just give me a chance to say goodbye and turn off the cameras here?
Nice job on the camera there, or not the camera, the
Directing over here. So I'll grab this, and I guess LeeAnn's right here. I'll say it to you, LeeAnn. Thank you all for joining us. Oh, I guess I better put that camera on, huh? There we are. Oh, you got it for me. Thanks, everybody. This has been fun. We look forward to doing other things with you. What are you showing them where? Oh, yeah, show them. That's what it looks like. It's healing up. Bye, everybody.